Good afternoon and welcome to today's in-service on the basics of non-small cell lung cancer. I am Karen Britton, a registered nurse and your presenter for today. I am the lead for the Interprofessional Lung Cancer Care Coordination Team, which consists of Joan Smith, Radiology, Tom Nelson, Laboratory, Angela Brighton from Complementary Therapies, Judy Miller, Dietitian, and Artis Simon from Quality Improvement. Thank you for attending the session. Learning Outcomes and SMART. Today, our specific audience for this in-service is our newly formed Lung Cancer Care Coordination Team. We will be measuring your knowledge of lung cancer using a pre-test followed by a post-test to assess knowledge gained. Today, we will be covering a brief overview of this chronic care target population with the goal of increasing your knowledge of this type of lung cancer. The goal for learning incorporates more than 3 SMART goals in that by the end of the presentation you will be able to identify care based on national standards, health promotion and risk reduction, pathophysiology, typical symptoms, critical assessment findings and meaning for treatment, typical diagnostic and lab testing, holistic therapies, and collaborative outcomes for health and wellness of this population. Overview of the chronic care population. Statistics according to the American Cancer Society 2016 estimates for lung cancer in the United States that 2 out of 3 diagnosed with lung cancer are 65 years and older. About 250,000 new cases of lung cancer are diagnosed annually, and it's almost a little short of 50% male-female, male being a little bit higher than 50% of those statistics. About 158,000 deaths from lung cancer occur annually. Black men are 20% more likely than white men to develop lung cancer. 85% of lung cancer deaths occur in smokers. Other risk factors include inhaled exposures typically related to occupational hazards, including things such as asbestos, beryllium, chromium, coal distillates, cobalt, iron oxide, mustard gas, petroleum distillates, radiation, tar, nickel, uranium, and air pollution containing hydrocarbons and benzopyrenes. Comorbidities must be assessed as they are important in determining the appropriate treatment plan. Hypertension, osteoarthritis, and cardiovascular disease are common in this population. In addition, other comorbidities such as diabetes, rheumatoid arthritis, dementia, and Parkinson's can be exacerbated by this new diagnosis and the treatments rendered. Goals of care based on national standards. The goals of care for the elder population based on national standards is to educate, treat, prevent, screen, and when a positive diagnosis is discovered, is to provide care based on the decision made collaboratively between the patient and the healthcare team. According to the National Comprehensive Cancer Network, NCCN, everyone should be informed of the dangerous health consequences of nicotine, including addiction and death. It is recommended that healthcare providers strongly recommend the use of affected tobacco dependence counseling and medication treatments to their patients who use tobacco. Chemoprevention trials may be recommended to current or former smokers in conjunction with low-dose CAT scan lung cancer screening for a select group of high-risk individuals. NCCN recommends that disease staging diagnostic decisions for suspected stage 1 to 3 lung cancer should be made by thoracic radiologists and surgeons that are board certified and that have extensive experience in thoracic oncology, in conjunction with a bronchoscopy expert such as a pulmonologist. The health and wellness of older adults are addressed in the Healthy People 2020 in the categories of sleep health, vision, respiratory disease, hearing and sensory communication disorders, and dementias. These areas of health and wellness are an important part of the overall elder assessment. Health promotion and risk reduction. Nurses have an important role in the promotion of health and wellness that can change the habits of the elder adult that places them at high risk for lung cancer. The goal is to promote healthy behaviors through the intervention of education regarding smoking cessation, support group referrals, stress reduction techniques, regular exercise, and nutritional guidance. Blyce, 2014. Healthy behaviors lead to risk reduction. Key risk reduction goals include decreasing the number of smokers and educating about the dangers of secondhand smoke. The evidence shows a 20 to 30% increase in the risk for lung cancer from secondhand smoke exposure associated with living with a smoker and from environmental exposures. Annually, 7,000 deaths are attributed to secondhand smoke exposure. Overview of the pathophysiology of lung cancer for the non-small cell type. The basis for lung cancer is a disease in which damage has occurred to the deoxyribonucleic acid, or DNA, causing what is known as carcinogenesis. The damage sustained causes cells to grow and develop at an abnormal rate and size. The damaged cells are unable to self-identify what type of cell they are and how to function appropriately. These mutated cells invade the space of other healthy cells and can travel throughout the body. In order for carcinogenesis to occur, it is believed that 3 criteria must be met. First, an exposure during cell replication to an environmental or dietary carcinogen, a virus, radiation, or certain hormones which cause mutation of the DNA. This is known as initiation. Once initiation has occurred, a promoter is needed to foster growth of the mutated cells, which can occur at any time. A promoter is a substance that can alter the genes responsible for a cell's function of growth and development, affect the cell's response to growth stimulation or inhibition, or disrupts intercellular communication, such as certain hormones or ingested chemicals. Progression is the last criteria in which the tumor has invaded or metastasized. Over 100 cancer genes called oncogenes, which activate cells, have been discovered by researchers. Precursor oncogenes, known as proto-oncogenes, are normally contained in human cells, along with tumor suppressor genes, and remain dormant unless they are altered by acquired or genetic mutation. In a healthy immune system, immunosurveillance is present, in which enzymes detect and either repair or destroy cells on a continual basis that have mutated. As the body ages, it becomes less efficient at DNA repair, which can lead to an increased rate of cell mutation, activation of oncogenesis, and inactivation of suppressor genes. The age-related changes set the environment for carcinogenesis. Some cells have a finite number of divisions and then go into a phase of arrested growth, in which they release tumor growth factors, and if they leave their regulated environment, can become extremely susceptible to malignant change. Symptoms and pathophysiology. Symptoms depend on what stage in the disease the patient presents. Patients tend to present at advanced stages of the disease, meaning stage 3 or higher, as symptoms do not typically appear prior to this. Commonly, respiratory symptoms are present. If the patient presents early in the disease, chest pain or discomfort may be present, which may include tightness or a sensation of pressure. The findings in late disease are typically dyspnea, wheezing, and a diagnosis of lung infections caused by tumor obstruction, a cough that may be the result of a pneumonia or bronchitis, chest pain with a deep breath, an abnormal respiratory pattern as a result of weakening respiratory muscles or changes in the diaphragm. Hoarseness, neck vein distension, dysrhythmias, and superior vena cava syndrome are caused by tumor obstruction and are linked to being cardiac in nature. Late manifestations include fatigue, weight loss, dysphagia, anorexia, nausea, and vomiting, with possible metastasis to the bone, liver, brain, and adrenal glands. Critical assessment findings and meanings for treatment. Treatment is based on the stage of disease and clinical findings at the time of diagnosis. Treatment can be curative to palliative or hospice care. Chest pain may be localized and mild to moderate. Hoarseness occurs as a result of the involvement of the laryngeal nerve. The intrathoracic spread of malignancy can lead to a unilateral paralysis of the diaphragm, dysphagia, and superior vena cava obstruction. The superior vena cava obstruction displays as upper body edema and distended neck veins as a result of black blood flow due to compression from the malignancy. Mediastinal involvement leads to pericardial effusion, cardiac tamponade, and dysrhythmias. Pressure from the tumor can cause hypoxemia, which causes dysrhythmia and can cause cyanosis of the lips and fingertips. Anorexia can occur for numerous reasons, including tumor location, food aversions, taste disorders, and psychogenic issues. On exam, ascites, a collection of fluid in the abdominal area, may be found. As the fluid collects, there may be bloating and complaints of abdominal pain. Large amounts of fluid may cause dyspnea. Constipation can be an issue due to the use of opioids for pain relief and is an issue at the end of life due to decreased solid and fluid intake due to dysphagia or decreased appetite. Neurological findings of extremity weakness may be detected on motor exam, indicating a brain stem or cerebrum lesion. Bladder tone or function may be affected by a spread of a tumor to the spinal region. These findings are all indicative of advanced disease and means that treatment may be palliative or hospice in nature. Typical laboratory and diagnostic testing aid in the screening, diagnosis, and monitoring of lung cancer and treatment response. Because of the importance of stage in the therapeutic decision-making process, all patients with non-small cell cancer must be staged adequately. A complete staging workup should be carried out to evaluate the extent of the disease. In the United States, the standard staging workup for 7 main components. Staging workup for all lung cancer patients should include CAT scan of the chest and upper abdomen, complete blood cell count with differential, serum chemistry studies such as creatinine, electrolytes, calcium, alkaline phosphatase, aspartate, aminotransferase. Sputum for cytology, in which a sample is collected each day for 3 days, which may reveal the histology of the cell type. Diagnostic tests of chest x-ray show size and location of advanced lesion. CAT scan of the chest indicates tumor relationship to surrounding structures and size. CAT scan of the brain and abdomen reveal metastasis, as do bone scan. Bronchoscopy locates tumor, and washings can indicate malignant cell type. Biopsy, such as a lung needle biopsy, confirms cell type. Node biopsy of mediastinum and superior clavicular may reveal metastasis. And thoracentesis, the pleural fluid, again may reveal malignant cells. Holistic therapeutics, pharmacologic therapeutics, varies based on stage of the disease. The aim is to treat the disease and control symptoms to keep the patient comfortable. Advanced stage medications may include anti-neoplastics, smoking cessation aids, pain control and shortness of breath may be controlled by morphine, sulfate, antiemetics for nausea and vomiting control, and laxatives for constipation. Complementary therapy such as music therapy, meditation, massage, exercise, and aromatherapy are also helpful. Collaborative outcomes and conclusion. The outcomes are disease remission when possible, achieving smoking cessation and symptom controls of dyspnea, anxiety, pain, nausea, vomiting, and constipation to increase quality of life. In conclusion, although there has been improvement in the quality of life measures for those diagnosed with lung cancer, there has been no significant improvement in the detection and survival statistics for those presenting with advanced lung cancer over the last 20 years, as noted in the graph. Prevention must be the key, not only in the realm of those afflicted by this disease who are smokers, but for the non-smoking lung cancer populations whose disease is triggered by environmental causes. Thank you.